the Nursing Post podcast, All Nursing All the Time with Ashley Moore and Rosa Horsley. This episode is about Alzheimer's, housing options, caregiver support, and some upcoming treatments. Our goal is to inform, help, and start conversation.
As Alzheimer's progresses, caregiver stress increases exponentially.
Absolutely.
And placement for patients with Alzheimer's is difficult for the patient and for the family. Nobody wants to put their family members in a facility, and most patients don't want to go to a facility. And we hope that this information that we're going to talk about today will be a little bit of help to some of the people that are in this situation who don't really know what to do.
Absolutely.
Or what option would be best for them.
For everybody, really. For caregivers, for
The
family
patient.
members, for the patient.
Yep.
So some housing options for residential housing options as care for patients with moderate to severe dementia continues. It can be very difficult for loved ones and caregivers to continue the care, from home. Maybe they had home health coming in and they only come about 2 or 3 times a week. And now it's to the point where patients are beginning to wander, they're beginning to become a little violent and have episodes from time to time. So if you have mild dementia,
Yes.
you can still do your independent daily living activities, right?
You can. And so because they're able to feed themselves, get up, do their ADLs, they really just may need a little additional support that you can get from an independent living facility. They'll help with housekeeping, cleaning, maybe laundry. Mm-hmm. They'll help with preparing meals, mm-hmm. and they'll help with their finances as well. So having somebody come in and say, these are the things that we need to do, this is what we can help with, and then the families can come in and kind of actually spend time, quality time, instead of saying, okay, let's make sure that we get the house cleaned, get your laundry done, that dinner's ready to go. Mm-hmm. They can actually just spend that quality time.
Well, think about it. They don't have to now worry about doing laundry once or twice a week or when
mm-hmm.
the last time the clothes were done, because they're in an independent facility now that is doing their laundry and housekeeping once or twice a week.
Or taking them to the doctor's office. That can be a huge help because, the doctor visits can ramp up with age.
Absolutely. When you start talking about progression and moderate dementia, this is probably the time where people may be looking for a little bit of a permanent placement, such as assisted living facilities, because they tend to bridge the gap between independent all the way to long-term care. So it's like that middle ground, that bridge. And with independent living, it's a combination of a lot of things, really. You get housing, meals, support services, and you get health care. A lot of times in assisted living, they have a medical director.
Yes.
And of course, it's the family and the patient's right to choose whether they want to have the house doc or whether they want to keep their primary care and still continue to go out to the office. But they offer transportation, so you're kind of getting the best of all the worlds here, because a lot of the stuff is being done down to medication administration. Right. A lot of times is being done in assisted living. These assisted living facilities are not governed by the federal government. They're actually governed by the Department of Social Services.
Right.
I know in Virginia, we're governed by the Department of Social Services. Lack of treatment for those who suffer from dementia with severe behaviors is kind of tricky. This is the part...
It is.
Where, red tape comes in and placement gets a little more difficult.
Especially with these assisted living facilities, because in the state of Virginia, assisted living facilities are a whole entity of its own, and they have their own
rules and regulations
that they have to follow.
And what may work for JCO doesn't work with the Department of Social Services. Let's say your loved one is now starting to display some violent tendencies, and it's more than on the occasion.
Right. And so what happens is assisted living facilities are required to do a mental health screening before admission if there is behavioral problems or a history of behavioral problems that have occurred in the last 6 months. And these behavioral problems are things that are suggestive of mental health disorders.
They're looking for aggression.
Right.
They're looking for wandering. They're looking for safety.
Right. And that's one of the big things that they're looking at. Yes, they're disabled. Yes, they can't help it. But yes, it still is a safety concern. And if that facility isn't able to keep the patient safe and they accept them, that is a big issue. It's a big problem. And so if they're going to harm themselves or either another resident, then that's going to be an issue. That's going to be a no-go to most of those facilities because they can't take on that liability.
No, because now you're having to not only protect that patient from themselves, but now you're having to protect them from all the other residents that, are living in the facility as well, and staff. I mean, a lot needs to be said about how, your staff and your caregivers in assisted living. It's a lot.
It is.
It's a lot when you're not taking care of a dementia population, and it's a super lot when you are. You have to have like a certain level of compassion and empathy in order to deal with patients that are special needs, because this is an intellectual barrier. It's like a special need.
Well, absolutely. And the more assistance and help that the patient needs, the more time and resources it takes from that facility.
Absolutely. But when let's say you have 100 or 200 residents, it gets hard to keep that one patient, let alone the other 199 safe.
Right. And so the nice thing is, though, say there was an issue and there was a concern, but that problem has since resolved. You figured out what was going on. Maybe there was behaviors and it was really not... It was more, they had a urinary tract infection and they were just off their rocker because they had the urinary tract infection. It's really not their baseline. That's not where they normally are. The facility has to take that into consideration, or they do take that into consideration. It has to be
well documented.
And it needs to be well documented.
Absolutely.
So if it's coming from another facility, like a hospital, another residential place, any other facility, any other healthcare facility, the assisted living facility is required to obtain a psychological and behavioral history before accepting the patient. And they have to keep this information, because if somebody comes in and the patient, one resident is being abusive to another, and somebody files a complaint and they look back and you don't have that paperwork, that's a problem.
If you didn't have it, or you had the information and you still accepted that patient into your population.
Yeah, that's a problem.
Yeah.
And then if they're coming from like a private residence, then what they have to do is just make sure it's well documented by friends, close family, and like maybe a primary care physician who is familiar with the patient, to make sure that they're meeting all those needs. And right now in the state of Virginia, they state that it's not required that that information be written from the family, which I think is crazy.
We document everything else.
Who made that rule?
If there's a change in condition, you have to document it. So this to me is,
But it still says they're not required to have written information, but the facility must document the source and content that it was obtained from it. But I would just say I need something in writing, in your handwriting, stating this, because otherwise they're going to say, well, you just wrote that.
Well, I know when I was, assisted living, I used to do the UAIs, the Uniform Assessment Instruments, and they're basically a mini clinical interview, and you would have to ask the patient and their family, are you incontinent, or can you dress yourself? Do you need any assistance with this? The big one was the psychological part. I mean, they have to be able to identify danger. So if we scream fire, the response that I was trained to look for is, if there's a fire here, how would you get out? Most of the time they would say through the window or through the door, which is the appropriate response.
Sure.
But if you have someone look around and tell you, I don't know, that's a number one indicator that they shouldn't be in an assisted living, because in a case of a fire, they don't know how to get out. They can't keep themselves safe.
They can't think independently.
Absolutely.
And with assisted living, if you have a patient, say that you accept them and things change, things have progressed, that patient will probably have to be discharged from that facility.
Yeah, so they have 30 days, the facility has to give you a 30-day notification, and they have to give you the reason why they've decided to discharge you. And I can pretty much say, for the most part, the assisted livings here, they really do try everything to retain that patient before they try to discharge you. So if this is new behavior for you, you're going to go see a psychiatrist, one that specializes in geriatric patients, because we need to rule out if that's the issue, and if so, therapy or, medication treatment would be appropriate. So most of the time they do try to work with you, but I can remember an instance where we had a patient with frontal lobe dementia, and for a lot of people who aren't familiar with that, they tend to have dementia earlier in life. Sometimes it's like in their 40s or 50s. Everything else is still active because this is a younger demographic than what you're used to seeing.
Yep.
But they also tend to be, a little bit more agitated and aggressive because the region of the brain that's affected is reasoning.
Yes.
I know from personal experience, this patient was very violent, and no matter what we did, there was nothing we could do, and it got to the point where they were hurting themselves by literally throwing themselves onto the floor face first. And we can't get them placement here if they're violent and cannot perform like 3 or 4 out of the 5 ADLs. They won't take them here in the local hospital. So we had to end up getting like emergency placement at a mental health institution.
Right. And that's one of the things that I don't want to say a loophole, but that's one of the things that makes that 30-day window narrow, is if they're at a point where they are harming themselves or somebody else and there's immediate risk or danger, they don't have to follow that 30-day
No, but
window.
They do have to give you 14 days.
Yes.
They have to give you an opportunity to have other appropriate living arrangements.
Right. So with severe dementia, you have long-term care and skilled nursing facilities, and they have services and staff to address things like nutrition. Mm-hmm. They can develop a good care plan. They help get the patient socially involved in different, recreational activities, and they also can help with spirituality and medical management. I know when I worked in skilled care, we had several times per week different spiritual people come through, different pastors or whatnot come through and hold different sessions at different times to make sure that everybody's needs are being met, and that was always taken into consideration.
I know the patients and the residents loved it because they would sing hymns, and it was like their upbringing when they went to church every week.
Yes. The downside is the staff to resident ratios at those facilities are usually not ideal.
I think that's a growing nursing problem.
Right, that is correct. Yeah. I would agree with that. On the flip side, they will, because the nurses work in that facility, a lot of them are familiar with people who have dementia and how to handle a lot of the problems. So you get some people that are well seasoned.
Absolutely. They were trained. I
Yes.
mean, the nurses are trained to deal with this demographic and to treat this demographic of patients.
And then in our state, that's like, we're regulated by the state. The state comes in and...
Jacob.
State comes in. I don't miss that.
I don't miss state coming every year.
Although I will have to say this. If you're doing a good job, it doesn't really bother you as much as you can't be in my nursing station that's enough room for my butt and expect me to do my job if you're in it.
Yeah, absolutely.
So there was a little time once where I'm like, in order for me to do my job, you got to go.
They do encroach.
And
they do encroach.
You can find a hole somewhere, but I need to be here where I can see call lights and residents and talk to them. You don't need to see that. So you can go to the conference room.
Absolutely.
And I'm staying here. And I just knew she was going to light into me. And she looked at me and she said, you're the first person who ever said, you're in my way to do my job.
Sometimes they need to hear it. I think people
she appreciated it.
Yeah, because everybody kind of tiptoes around them. I think if they realized if you train your staff from the beginning the correct way and according to the standards, then it won't be such a stressful time when they actually show up because you're already doing everything you're supposed to do.
Exactly.
So we know dementia is very difficult on the patient, from diagnosis to moving to a facility. We understand transfer trauma happens, trying to get acclimated. But we also know that the caregivers need support too. And they're stressed out too. And we want to give those caregivers some relief and some tips to help them deal with the stress that comes with caring for someone.
So a couple of things that you can do to help with your stress level is use things like visualization, which means that you just kind of go into a nice, quiet place and visualize something that makes you happy. I mean, and some people even get to the point where they actually use like vision boards for this.
Oh yeah, I love vision boards.
So if you're not a person who can imagine the cool breeze,
the zen,
and the Caribbean Ocean with a drink with an umbrella, see, I can picture that really well. And me about 30 pounds lighter, I mean, I look good in my vision.
You look good now. You look good now.
You can use like a vision board, and it's just things that make you feel good.
Mm-hmm.
That
make you happy.
And so when you're happy, your body releases those good endorphins, and it kind of gives you that push. Meditation?
Yes. Your namaste, your zen.
Yeah.
That happy place times 10. So even just taking a break, it doesn't even have to be a long break, 10 to 15 minutes where you just kind of sit there in silence, classical music, whatever makes you calm and peaceful, and you just do that for 15 minutes, no outside distractions. Just let all your thoughts go.
I don't know where you're going to go for 15 minutes without outside distractions, though, because I can't find that.
I can't even find it in the restroom.
Another tip, breathing exercises. And so this is just focus on your breathing. Like, you can do this in just a couple of minutes. I mean, when people tell you to like walk away and count to 10, this is what you're doing.
This is what
they mean. Like, sometimes you actually literally need to breathe. You're sitting there tense and you're holding your breath and you don't even realize it. And it's like, breathe. It's okay.
Yeah, slow and focused, nice and even. If you have a watch like mine, it tells you what to do and for how long to do it. I have a love-hate relationship with that watch.
I'm not doing that. I got enough things beeping and telling me what I need to do. I'm not putting it on my wrist.
So progressive muscle relaxation, tightening and then relaxing each muscle group and starting at one end of your body and then just kind of working to the other end. So you just kind of start with the top of your head all the way down to your toes, and you just kind of try to release that tension.
That sounds
and that
fabulous.
Stress buildup. I'm in my mind thinking about doing all four of these things at the same time, but I'm not sure if you'll get much work out of me.
But afterwards you might be super productive. Like, I'm ready to go.
I might feel like I'm ready to conquer the world.
And you could get moving. Just 10 minutes of exercise, even if it's just like a walk or
absolutely
gardening.
A hobby, anything actually. Just
sewing,
get out and
whatever you want to do. Just maybe yoga with a friend. Mm-hmm. There's chair yoga if you can't get in the ground.
Absolutely.
Whatever tickles your fancy, but just doing something 10-15 minutes every day for you, it's just huge.
It will make a big difference. It'll make a big difference physically and mentally. You'll just feel a lot better. But you have to find that balance. Like, you really do have to etch time in for yourself. When you're consumed with trying to juggle everything and you're not taking time out for yourself, things become a lot more overwhelming.
Mm-hmm.
You want to consider taking advantage of respite care, where you can spend some time doing things that you enjoy And respite care provides caregivers that temporarily give you a break. And that way that patient or that family member can place that patient in respite care, and you can still do some things that you need to do.
Well, even if it's something as simple as a family member comes over, a friend comes over and says, hey, go do something for yourself. Just go. Don't, no, I have I have to do. Say, you know something? That sounds great. I'm going to go get my nails done. I mean, you can't do it right now.
No. When things go back to normal.
Go get your nails done. Go get your hair done. Go get a foot massage. Go to the grocery store without having to run back home. I mean, there's so many things that you could do. Go sit in a park and do nothing.
Yeah, I like to watch people.
That's so fun.
Yeah,
people watching.
I like to be in public and just, watch the world go by.
Yes, it is fun.
Educate yourself. If you're the caregiver, we've said this all along, I think in almost all of our episodes here, like, you need to be informed. How can you make informed decisions if you're not educated?
Right, and that's one of the reasons why we wanted to do this podcast, was to inform and open up people's minds to the different issues and ideas surrounding nursing. And if you're a nurse, you've encountered these people at some point in time. And so to be able to give this information to your patient or your patient's family, that's huge.
So you want to make sure that you know what resources are offered and available in your community. You want to know about the adult programs, the in-home assistance, the visiting nurses, and the meal delivery. And you want to get connected with your local Alzheimer's chapter. I know the one here in our area does family support groups very often in a lot of different places, so that caregivers can go and meet other people that are going through some of the same circumstances or have already been through that circumstance, and they kind of help each other and depend on each other, and they become a little community. So they might be able to give you some tips.
Oh, absolutely.
Some tips on taking care of yourself, keeping your regular doctor appointments, because if you're not well,
you can't take care of anybody else.
Thank you.
No, you have to take care of yourself to be a good caregiver.
I totally agree. And while things are mild and not as hectic, this would be a good time, to start financial planning, trying to get your affairs in order, or your loved one's affairs in orders. Everything happens so fast, you want to be prepared.
Absolutely. You need to be thinking about who's going to be your POA, or who is going to be your medical person in your family that assist. And we talk about this at work now, like make sure that you have your, what is it called? It's a durable...
It's a DDNR.
Not the DDNR, but it's another...
an advanced directive. Yep.
That's what I'm thinking of.
Your DDNR.
Right. And so those are the things that you need to start thinking about.
Yeah, how, if we're doing burials or cremations, all that stuff is so much better being planned ahead than after the fact.
And there are attorneys who specialize in elder law who could really help with that.
Absolutely.
It'll be probably, I'm sure, costly when you're talking about any kind of attorney fee, but it'll be well worth it.
Less if you prepare than if you wait. So there are some scientific researches and breakthroughs happening, and even though there are currently 234 clinical trials that the National Institute of Aging is currently supporting, the bulk of these being on non-pharmacological interventions, followed by caregiver interventions.
I found that to be completely interesting, that's the highest numbers of studies are not for medications.
I find it interesting. I kind of find it, to the other topics that we've done, kind of right in line.
So there's a beta amyloid study, and it is the beta amyloid is the chief component of plaques found in the brain, and it's one of the hallmark signs of Alzheimer's.
Yes.
So these plaques form between nerve cells in the brain, and they interfere with the neuron-to-neuron communication. And so that enables the brain to store new information. And that's the problem, is they're not able to process new information. So there are two anti-amyloid compounds, because we don't want amyloid, because
We don't want plaque.
we don't want plaque. One called a CAD 106 and another called a CNP 520. And they are currently being studied to determine if they can prevent or delay symptoms of Alzheimer's among the higher risk, cognitively healthier older adults who have genetic abnormalities. So these are people who are genetically predisposed to Alzheimer's. Maybe their family members had it. They've done genetic testing. They found some strands that they know that are associated with Alzheimer's. The two studies are known as the Alzheimer's Prevention Initiative, so API, and there's a Gen 1 and a Gen 2. They will determine if these drugs can combat the accumulation of those plaques.
Mm-hmm. So this is what studies have found. Beta secretase, which we're going to call BASE because that's what they've decided to call it.
Sure, works for me.
One of the enzymes that clips APP, BASE, makes it possible for beta amyloid to form. Therapies that interrupt this process may reduce the amount of beta amyloid in the brain and ultimately intervene with the development of Alzheimer's. So, like you said, we're trying to block plaques from forming. And this is one of those, one of those enzymes and medications that they're trying to use to help from forming.
Yes, and there's another medication, and this medication doesn't even have a name.
I think it makes it easier to pronounce.
But it is J&J-54861911. I was like,
Pretty
really?
long.
That's the name of this? But whatever that is, this J&J inhibits the ability of this beta secretase enzyme to make the beta amyloid. So it's stopping the brain from making this beta amyloid. This is actually in a phase 3 right now, and it is being studied to see if it slows cognitive decline in patients who do not have Alzheimer's symptoms but have already shown elevated levels of beta amyloid in the brain. So that's one of the things that I have researched is plaques that they find on imaging, on brain imaging, can be found 10 years before symptoms even start.
That's crazy.
We don't scan people's brain just to say, wonder if you're going to have Alzheimer's. Let's see.
Just for the heck of it.
We don't do that. And so that's crazy that if we find that this actually helps prevent the formation of it, I wonder how much of a head start we can get with treatment.
Well, if we're screening, this is what I wonder. We screen now, but generally if you go to a regular PCP, they're giving you something like a clock and telling you to fill it in.
Yes.
So
the 3-word test.
Or the 3-word test. So if we start screening more so than here, right in this clock.
Right.
What we can find.
And that last study is actually expected to be completed in 2024. So in 4 more years, that's not a long time for studies. And if that shows significant
promise, I mean, it's already in phase 3, so it has some promise already.
Yes, it really does.
And it's in a pill form.
It is pill form, which is easy. Patients like pills versus the other alternative.
Yeah, injections or anything else. So one of the things that I had read that really sparked my interest were the nano devices.
This is so cool.
It is so cool because when I think of nano devices, I'm thinking about what you see like in the movies, kind of like Matrix for medicine.
Yeah.
Like Matrix with Keanu in medicine. Like it just gets me a little excited.
We're getting our nerd on.
Yeah. So in a multidisciplinary study, scientists at the U.S. Department of Energy, Argonne National Laboratory, that's so long, and along with the Korean Institute of Science and Technology and the Korea Advanced Institute of Science and Technology, they've developed an approach to prevent plaque formation by engineering a nano-sized device that captures the dangerous peptides before they can even assemble. So researchers covered the surface of the new nano device with fragments of an antibody.
Yes.
I think we're all pretty much have a basic understanding of what antibodies are.
Yes.
So what it does, it recognizes and binds to the peptides. So the surface of the nano device is spherical and porous, and it's like a craters that maximize the available surface area for the antibodies to cover it. Mm-hmm. And then the more surface area means the more capacity for capturing these peptides.
Yes.
And what I found so interesting is that these little nano devices, like in your mind, you're probably thinking something big and huge.
Yeah, it is. I was like, how do they get these nano devices in you? Like, that was my first thought when I read this study. Like, how do they go in you? Like, how big are they?
Yeah, you're thinking, like, it sounds like it's too cool. If I was coming from the outside and I was thinking about this, I'd be thinking, like, of spaceships. But it's so much smaller than that. It's like 100 times, 1,000,000 times, like, smaller than your hair.
They say thousands of them can fit on a strand of hair. So that tells you how small these devices are. I want to know how in the heck you work with something so small. I mean, I can hardly sometimes clip a necklace behind my neck. And these people are working with nano devices.
Thread string through a
needle. The struggle is real.
But it's so cool because
this is awesome.
The idea that these nano devices could collect these peptides as they fall away from your cells that are already in your brain, so they don't form into plaques and they kind of just discrete them. It's fascinating to me. It's so cool. And that this technology could also be used for other neurological diseases like abnormal protein deposits that you find in Huntington's or in Parkinson's. It just makes me even more excited.
Yeah. And me thinking, or not thinking, I'm like, I wonder what these things look like. I need like a visual aid here, and it's on YouTube.
Everything's on YouTube now.
So if you're curious, you got to look it up on YouTube. Yeah,
it's awesome. It's amazing.
Awesome. Another study is a tau protein. It is the chief component of tangles, and that is another hallmark sign that you see in imaging for patients with Alzheimer's. And that protein helps maintain the structure of the neuron, and the neurons have these microtubules that deliver nutrients throughout the neuron. And so what they're trying to do is prevent the tau protein from collapsing and twisting into the tangles. And in turn, it helps keep the neuron from being destroyed.
It looks pretty good. It's in phase 2 of clinical trials.
Yes.
And that's an easy one to pronounce. Adamant.
See, they thought of us, I'm sure.
They knew we were going to struggle if it was anything less than.
It's not a pill, though. It would be a vaccine.
I can deal with that.
But if there's a vaccine to slow the progression of a disease,
we would take it, right?
I would take it.
You know, it works in other areas of life. The flu shot, your MMR.
I'm good with those. I had all those.
Yes, me too.
So Alzheimer's disease is difficult. And there's no cure on the horizon for this. I mean, all these research, of course, I didn't read all 234 on the National Institute of Aging's website. If you want to, you go for it. Let me know what you find out. But we didn't read that many of the studies. It's kind of sad in a way that we're not, to me, it doesn't seem like we're very close.
Yeah, I would think we would be a little further advanced.
But as research continues,
there's hope.
There is hope. And until we can get to a point where some of these medications are out to help slow the formation of these plaques and tangles and different protein buildup or whatever it is, until we can get to that point, I think that our focus should be on non-pharmacological ways of intervention and educating patients, caregivers,
providers,
nursing providers
facilities.
On these other options out there besides
medicine.
Besides medicine.
I agree.
Because these patients need to be treated with dignity and respect.
Absolutely. And that's what their loved ones are really wanting, for them to be treated with respect and dignity. So we want to thank you for listening to this episode. And of course, we will link our references to our website, www.thenursingpostpodcast.com. Be sure to check back next week when we discuss scleroderma.